Saved from a surgeon's blade, hypercalcemia due to fungal infection in a 60-year-old patient with history of HIV. Quick facts about hypercalcemia. Three most common causes are malignancy and primary hyperparathyroidism, which make up more than 90% of cases. Granulomatous disease such as sarcoidosis, fungal infections, tuberculosis make up less than 10%. For reference, anything over 14 is considered severe hypercalcemia, and these patients not uncommonly present with lethargy, confusion, even coma. Our patient presented with a calcium level of 14.1 but was alert and oriented ×3. He also reported having polyuria, polydipsia, and constipation. We immediately started him on continuous IV hydration and gave him a shot of zoledronic acid. His calcium level normalized to 10.1 over the next 3 days. So the acute management was pretty straightforward, but he did have a pretty complex course over the past 3 months. He had presented initially with a CD4 count of 72 after not having been able to receive art therapy for 5 years due to insurance issues. At that time, pan-CT scan showed extensive lymphadenopathy in his mediastinum and multiple lesions in his spleen, so lymphoma was pretty high on our differential as he's someone with untreated HIV with extensive lymphadenopathy. He, however, did not have an easy-to-biopsy lymph node. His mediastinal lymph nodes was assessed too hard to reach by our cardiothoracic surgeon, and the endobronchial approach would not be useful because a fine needle aspiration cannot reliably diagnose a lymphoma. He was referred to a general surgeon who recommended doing a splenectomy because the radiology report had suggested it was very suspicious for metastatic disease. That was the #1 consideration on our differential as well. So it wasn't an unreasonable suggestion. Patient was actually scheduled for a splenectomy as well. But after this presentation, we reviewed his chart closely and we found evidence that he was actually responding to treatment for a fungal disease. After the initial presentation, his primary care physician had him on a antifungal treatment for a few weeks. We had evidence his mediastinal lymphadenopathy had decreased. His fungital level had decreased from off the charts being greater than 500 on our scale to 299 on this presentation. So we discussed with his oncologist and the interventional radiologist, who both felt that he did have some lesions which was easy to access with an acceptable risk of bleeding. We were able to successfully get a splenic biopsy. The fungal studies on that splenic biopsy came back positive for coccidiomycosis, and the pathology report says no concern for malignancy. So essentially, this was hypercalcemia due to granulomatous disease caused by a fungal infection, specifically most likely disseminated coccidiomycosis. The mechanism for that is hypercalcemia due to increased vitamin 125. This was seen in our patient where the vitamin 125 was near the upper limit of normal, but the normal vitamin 25 was within normal limits as expected, and this is thought to be due to activity of macrophages. So I guess learning point here would be, as internists, we should always do judicious evaluation and leave surgery as the absolute last position if we can. Thank you.